Good morning, everyone. I'm Craig Hanlon-Smith, and I'm the Centre Principal at the North Kensington Centre, part of Morley College, London. And welcome to the first of two Penny Lectures today, which is celebrating International Nurses Day, and also in recognition that this is Mental Health Week. I would like to welcome, to deliver today's Penny Lecture, the first Penny Lecture, Dr. Tommy Dickinson, who's a reader in nursing education, and also the head of mental health nursing at King's College, London. Tom is going to deliver his lecture, which is based on his book, Curing Queers, which he'll talk in much more detail about. And there'll be an opportunity at the end for you to ask questions. How that will work is if you put the questions in the chat, type them into the chat, and then I will ask Tommy the questions as part of this lecture at the end. So without further ado, Dr. Tommy, welcome.
Thank you so much for the introduction, Craig, and for the invitation to speak today. Such a privilege to speak on International Nurses Day. So I am a mental health nurse myself, and I trained as a nurse back in the 1990s. And I remember being a nursing student on placement at an old psychiatric hospital that's closed down now. And a patient came in with his partner, and his partner was living with dementia, and it got to such a stage that his partner couldn't cope with him anymore, and he had to bring him into this hospital. And I remember his partner was so incredibly upset about this. And I was an 18-year-old nursing student at the time. And obviously I was thinking, well, he's upset because he's having to bring his partner here, and, his partner's going to have to stay in hospital. That's understandable. But when I spoke to him a bit more in depth, he told me that his partner had been admitted to this hospital when he was 18 years old in the 1960s to receive treatment to cure him of his homosexuality. And he had made a promise to his partner that he would never need to go into this hospital again. And the reason why he was so upset was because he was kind of breaking that promise. He'd had to bring his partner back into the hospital where he had received this treatment so long ago. And it got me thinking, gosh, I must find out more about that. So fast forward around 17 years, and I decided to write a book on it. And essentially that's what I'm going to be talking about today. So my book is called Curing Queers, Mental Nurses and Their Patients, 1935 to 1974. And essentially what this book explores, what my research explores, is the former medical treatments that people received to cure them of homosexuality or gender identity issues during the 1930s to the 1970s. So I'll quickly give an overview and a rationale for those dates. So 1935 is the year that the first official report on the use of aversion therapy was published in a medical journal. Aversion therapy to cure homosexuality was published in a medical journal. And 1974 is the year that the American Psychiatric Association removed homosexuality as a classification of mental disorder. So that's the reason for those dates. It's important to point out, though, that the World Health Organization didn't actually remove homosexuality as a classification of mental disorder until 1990. However, these treatments that I'm going to be describing today did peter out in the mid to late 1970s, mainly because of one of the reasons is because of the American Psychiatric Association deciding to declassify it as a mental disorder. But moreover, the gay liberation movement were gaining momentum during that period, particularly during the mid-1970s, were gaining momentum during that period. And gay men and women were uniting and refuting that sickness label that had been attributed to them. So that's one of the main reasons why the treatments petered out. So so that's what we're going to be talking about today. So the main sources of information in my research was oral history. So I did oral history interviews with people who had received these treatments and nurses who administered them. Now, I do need to point out that the testimonies that you'll hear today contain some quite graphic descriptions of the treatments that members of the LGBT community were subjected to, which some people may find distressing. So I do need to kind of just give that trigger warning. These oral histories were also supplemented by archival searches and using archival material in the archives at the Hall Carpenter Archives, which is at the London School of Economics, the Royal College of Nursing Archives, which is up in Edinburgh, the Lesbian and Gay News Media Archives, known as LAGNA, at the Bishopsgate Institute in London, the Wellcome Trust Library and the National Archives. And we'll be looking at some of the material I found in these archives throughout the lecture. Now, I managed to recruit 8 participants, so 8 former patients who received this treatment. Now, it's been estimated that about 1,000 people received this treatment that I'm going to be describing, and which was given on the NHS. So of the 8 patients that I interviewed, they were all male at the time they received the treatment. However, 2 later underwent gender reassignment surgery and are now living as trans women. And at the time of their interview, their ages ranged from 65 years to 97 years. So I also managed to recruit 17 mental health nurses. At the time, they were known as mental nurses, registered mental nurse. That was their formal title. And they consisted of 8 men and 9 women, so quite evenly distributed in terms of gender. At the time of their interview, their ages ranged from 63 to 98 years old. 2 commenced nursing in the 1930s, 5 in the 1950s, and 8 in the 1960s. And all these nurses worked in the NHS, and the treatments that I'm going to be describing today were all given on the NHS as well. So I want to quickly run through, very quickly, we haven't got enough time to do this in detail, but very quickly, the medicalisation of sexual behaviour. So sodomy was initially outlawed as a capital crime in England by the 1533 Buggery Act of Henry VIII. And then in 1886, Krafft Ebing, who was a professor of psychiatry at the University of Vienna, published his seminal Psychopathia Sexualis. And this was the first medical or clinical analysis and formal classification of most major, what were known as sexual perversions. And under the auspices of that fell homosexuality. So early attempts to cure homosexuality initially used hypnotherapy, and Krafft Ebing was a huge advocate for this. And he reinforced this treatment by encouraging his patients to visit local brothels. Then, from a UK perspective, in 1897, Havelock Ellis and John Edmonton Symonds published their masterwork Sexual Inversion, and this was the first British attempt to synthesize biological, anthropological, and psychological knowledge on the subject of sexuality. And then in 1905, Freud came along with his 3 essays on the theory of sexuality. Initially, they were published in German, but following translation, his work began to have a pioneering influence in the treatment and understanding of sexual deviation in Britain. And then in 1935, and this is where my study starts, this was the first report on aversion therapy being used to treat homosexuality. So this is the paper that I was talking about, and we can see it here. It was at the bottom of the slide. It was by Louis Max. And he required a homosexual patient to fantasize about an attractive same-sex sexual stimulus in conjunction with receiving strong, in his own words, electric shocks. And this is what we're going to be focusing on today, these subversion therapies. So what were these treatments? So I'm going to talk about them now, and I've got some slides on here to add a bit of context to them. So there were two types of aversion therapy. There was chemical aversion therapy and there was electrical aversion therapy. So let's look at electrical aversion therapy first. And we've got two examples of this on these slides. So bottom left, we've got somebody having electrical aversion therapy here, and on the right hand slide. So what this would involve, it would involve the patient would be treated as an outpatient at a psychiatric hospital, and they would usually be treated for at least one day up to 3 times a week. So they would go in, and usually for about an hour, 3 times, or 1 to 3 times a week, and they would go into a room within that hospital, as we can see here on the right hand side. And in that picture there would be a wooden chair which they would sit, and we can see the patient sitting on the wooden chair in two of these pictures. And in front of them there would be a projector screen that would be showing pictures of naked women or naked men. And their hands, their feet, or their calves would be attached to electrodes. And we can see that here. The bottom left-hand picture is the patient's feet are attached to electrodes, and on the right, the patient's hands are attached to the electrodes. And what would happen is the patient would be shown a picture of a naked man and would be given an electric shock. And it was usually the nurse who was pressing the button to give them an electric shock. And then they would be shown a picture of a woman, naked woman, as you can see here on the right hand side, and they wouldn't receive an electric shock. And essentially this was based on Pavlovian classical conditioning. You was to associate the pain of the electric shock with the image of the man that you were seeing in front of you. Now sometimes the electric shocks were given automatically because the man's penis was attached to a penis transducer, and if there was any change in that detected, then they would be given an electric shock. So that was electrical aversion therapy. Chemical aversion therapy was much more invasive, and the patient would be nursed as an inpatient on a psychiatric hospital. So they would be admitted to the ward, and they would be taken to a room, such as the one in this top left-hand picture. And in that room, there would be nothing except a bed. There would be no toilet, no basin, wash basin, no, just a bed. And there would be pictures posted all around that room of men, naked men, and a strong light would be shining on those. And every 2 hours, the patient would be given an injection of apomorphine. The nurse would come in and give them an injection of apomorphine, which was a really, really powerful emetic, so it made them violently vomit. And this would go on for up to 3 days, so up to 72 hours. They were kept awake by means of amphetamine at night, and every 2 hours they were made to vomit. And they were not allowed out of that room for 3 days, for up to 3 days. And as I said at the beginning, there was no toilet, no basin, nothing in that room. So you can imagine after a couple of hours, after you've been made to vomit, let alone 3 days, patients were lying in their own elimination. And that was the whole point of the treatment. You was to associate the circumstances in which you were in, i.e. the mess around you, your own elimination, with the pictures of the naked men. And also what would happen is the consultant psychiatrist had often pre-recorded a video, a kind of recording that was on loop that was saying pejorative things about the patient, such as, look at the mess you're in. This is because you're a disgusting, dirty homosexual. If you were to see the error of your ways, you wouldn't be in this mess. And this was constantly played to them, as well as being made to vomit and in their own elimination. After 3 days, the patient was allowed out of their room. The nurses would come in and clean the room and change the pictures to naked women. the nurse would give the patient an injection of testosterone, and when the testosterone had become therapeutically effective, which could take a couple of hours, they were encouraged to go back into their room and masturbate over the pictures of the females. So that was chemical aversion therapy. And the treatments that I've just described, both electrical and chemical aversion therapy, were both given on the NHS. So let's have a look now at some of the other treatments that were given. Although my study didn't focus on them, it's important to have a look at the other treatments that were given. One of the other treatments that kind of came before aversion therapy was estrogen treatment, or chemical castration, as it was colloquially known. And probably one of the most infamous recipients of that was Alan Turing. Then what could also occur was the patient could go on what was called social skills training. So after the treatment, the electrical or the chemical aversion therapy, the patient would sometimes be encouraged to go to spend time with the female nurses. And this was colloquially known as some of the nurses that I interviewed colloquially kind of nicknamed this going on dates with the patients. There certainly wasn't supposed to have any intimacy with each other or anything like that. It was essentially about building the patient's confidence around women so that they could, when they were discharged, they would feel comfortable asking women to go out for dates, etc. The main thing, though, was that there was no general protocol or ethical guidelines for these treatments. The treatment of choice was very experimental and usually based on the unilateral decision of the consultant psychiatrist, underpinned with no firm evidence base. So essentially what you could have somebody having this treatment in Manchester who might have chemical aversion therapy, and then somebody having it in Belfast, for example, and they're having electrical aversion therapy. There was no coordinated approach to this. It was essentially the consultant psychiatrist saying, well, I think this is the best approach, so we're going to do that. So let's have a look now at some of the reflections on the treatments. So all the testimonies that I'm going to be reading today, I'm going to read them myself, but they're actually words of the people who I interviewed, and the people that I interviewed are on the screen here. So this is Greta Gold's reflections on the treatment. And Greta Gold had electrical aversion therapy. So quote, I remember sitting in the room on a wooden chair, dressed, wearing women's clothes, but I had to be barefoot as my feet had to touch the metal electrical grid. My penis was also wired up to something to measure if I got an erection. I felt totally violated. I remember the excruciating pain of the initial shock. Nothing could have prepared me for it. Tears began running down my face, and the nurse said, "What are you crying for?" "We've only just started." I was speechless. So this is Herbert's reflections on the treatment, and Herbert had chemical aversion therapy. I can still taste the vile taste of stale sick in my mouth, and all I wanted was to wash out my mouth with fresh water, but I wasn't even allowed that. I remember trying to sneak out of my room one evening to get some water, but the nurses caught me and literally threw me back in. I wasn't allowed out of the room for 3 days. I went to the toilet in the bed. I had no basin, no toilet facilities, nothing. I had to lie in my own feces, urine, and vomit. I was in a terrible state. So why did these people, and I'm predominantly using men in this study, although I did say that 2 people who underwent the treatment are now trans women. At the time they were men, and all the people that I interviewed, that had this treatment, who I interviewed, were having it because of homosexuality. I do predominantly talk about men, but these treatments were also administered to women as well, to a much lesser degree. And one of the reasons I argue for that is, homosexuality among women was never illegal. So it's never, but it was for men. Male homosexuality was illegal in England and Wales until 1967. And we'll see in a minute how, being prosecuted could also lead to this treatment. So one of the reasons, so the main reason that men and women sought these treatments was because of the turmoil they found themselves in when they realised that they were homosexual. They were also referred through the courts, prison or hospital. So as I said, it was illegal. Male homosexuality was illegal until 1967 in England and Wales. Places like Scotland and Northern Ireland would take until the 1980s, and places, some of the Channel Islands, for example, and the Isle of Man, took until the 1990s to decriminalise homosexuality. So people were given a choice of going to prison or to hospital to be cured. But the main driver was the unsupportive family, police, social and media attitudes. And we've got some examples of this here. So these are two newspaper articles from newspapers at the time. So if we look at first on the right hand side, the Observer report, which is entitled How a Doctor Cured a Homosexual, which was published in 1962 by the medical correspondent of the Observer. And essentially what Dr. Abraham Marcus is relaying is a paper that was published in the British Medical Journal that was purporting to have cured a gay man using aversion therapy, chemical aversion therapy, like I've just described. And there was no critique of this in the article. It was given quite, celebratory as something, a kind of revolutionary treatment that could solve the problem of homosexuality. On the left is an article from the Sunday Pictorial entitled Twilight, meaning homosexual. I'm not sure where that's come from, meaning homosexual men, now they can be cured. And again, this talks in a quite celebratory manner about these treatments. Now, what I think is most disturbing and interesting about this particular article is that you have a Twilight man looking furtively at children playing in a park. And I think what that did is it reinforced the familiar stereotype at the time that homosexual men have paedophilic tendencies. So the news media were very, very influential in kind of promoting these treatments, as the next testimony we'll see in the next testimony. So Uhtred is reflecting on the reasons why he had this treatment. So, quote, "I was a veterinary student, and I'm sure you can imagine it was a very masculine environment, spending lots of times on farms. And I knew I was queer, as they called it then, but I was desperate to be normal and like all the other lads on my course. I remember we were in the common room one Sunday morning, slightly hungover from the night before, and the lads were taking the mick out of each other. And as they had read an article in the Observer about a homosexual being cured, they were basically saying, 'Look, James, there's hope. You can be cured.' I remember joining in with the bravado to fit in. However, once they had all left, I took the paper to my room and I read it properly. I remember feeling a sense of hope, as most of the other things I read about men like me were pejorative, to say the least. Anyway, I made an appointment to see my GP the next day to ask for this treatment. So Uhtred went to his GP, who then referred him to a consultant psychiatrist in the NHS for this treatment. So Albert, these are his reflections on why he received these treatment. So, quote, "It was terrifying, really, because I was thrown into confusion, and it made me very poorly because I had 3 children, little ones, and a wife. and we all loved each other, and we'd been happily building our lives, you know. I was very fond of my wife as well, and everything was going okay. And then all this began to happen and threw me into awful confusion, and it made me very, very poorly. So I thought, I have to go to the doctor. So I did. So Albert again went to his GP, who once he told him his story, that he was having kind of homosexual feelings, the GP referred him for this treatment to the NHS. Now, Percival is quite an interesting person. So Percival was he was a butcher. He took over his family's butcher shop, and one in London. And one evening, he was walking home from work from his butcher shop, and decided, in his own words, that he would visit a public toilet, and in his own words, he went there looking for love. And when he went there, he was approached by a very attractive young man, who made a sexual advance towards him. And when Percival responded to that advance, he was arrested. The young man was an undercover police officer. And entrapment by police officers such as this was very common in the 1950s and 1960s. So this is Percival's reflection on the treatment. Quote, "So when I was given the option, prison or hospital, well, I just thought, if I go to prison, if the other inmates found out what I was in there for, well, I just thought they'd kill me. I mean, I was fairly accepting of my sexuality, but in society, and particularly within a prison, it was viewed in the same light as a paedophile. No, I'm not going to prison, that's all I could think. So I just said, yeah, I'll go to hospital for the aversion therapy. I knew it wasn't going to make me straight. I didn't want to do it. I didn't want to go, but it just seemed a better option than prison. So, as I said, he was arrested and taken to court for gross indecency, and then was given the option of going to prison or to hospital to receive this treatment. And as we've seen, he chose to go to hospital. So they were the patients. And I also, as I said at the beginning, interviewed the nurses who administered this. So being a mental health nurse, this really fascinated me, because as we've described, as I've described and as we've seen, these treatments, you know, were very invasive and brutal to the patients. And it kind of, you know, we often think of nurses as you know, being there to support people and to care for people. And obviously the treatments that I've just described, arguably, you know, it was quite the opposite. So it really interested me about, why did the nurses do this? What was going on that kind of made this acceptable to these nurses? People, you know, would I, you know, often, if I'd have been a nurse during this time, would I have done this? I'd have liked to think I wouldn't, but, you know, what was going on? So during the process of my analysis of the data, so my analysis of the interviews with all these nurses, it became quite apparent that the nurses fell into two groups. And the majority fell into this subordinate group. And some fell into the subversive group. So by the subordinate group, I essentially mean that they just did as they were told. They followed orders. And I've subcategorized the subordinate group into three subcategories, insofar as it is possible to categorize. So these are nurses who were unquestioning and uninquiring. So the majority were, you know, they said, well, we didn't have to ask questions then. It was the doctor who, you know, we just did what the doctor told us to. We weren't trained to think, we weren't paid to think, we just did the doctor's work, which is very different to nursing now. We're much more autonomous clinical practitioners who make our own sound clinical judgments, who, you know, and will question, you know, question doctor's orders or any orders if we don't think they're in the best interest of the patient. So another one, some others sensed that there was something wrong in what they were doing, but overcome their reservations by limiting their culpability. And essentially they did this by, so for example, you know, if they were giving the chemical aversion therapy, they would say things like, well, I only did the injections, and John put the pictures up in the room, and Claire, you know, changed the bed after, he did all the cleaning after the treatment. So it was almost like this shared responsibility. So because it was this shared responsibility, there wasn't an individual onus on an individual to kind of go, oh, is this wrong? Because it was essentially, well, they're doing it, so it must be okay. So it was this shared responsibility, and that essentially limited their culpability. And then there were some nurses who genuinely believed that they were acting beneficently. So they genuinely believed that they were acting in the best interests of the patients. And quite even more interesting is three of the patients that I interviewed, three of the nurses that I interviewed identified as gay men. So they identified as gay men and said, well, I was a nurse, a gay nurse, and I did actually give these treatments, which I thought was absolutely fascinating. And this is an aspect of the book that, you know, that is I go into it in a lot more detail in the book. But essentially, what those nurses said was that they felt at ease with their sexuality, whereas the patients in front of them were in complete turmoil, and they were desperate to change who they were, and this was the only option available at the time. So that's how the gay nurses kind of grappled with their own morality of administering this treatment. And then there were the nurses who fell into the subversive camp, and these were the most interesting and fascinating, because essentially what these nurses did was they got out of giving these treatments in quite clever and fascinating ways. And we'll hear one of the subversive nurses shortly. So this is a reflection on one of the subordinate nurses. So this is Gilbert Davis. So this is his quote. Our job to all intents and purposes was to follow the doctor's orders. I mean, you have to understand the power of the doctors, nursing officers and matron in those days. You stood up to attention with your thumbs down your creases, for example, when the doctor came on the ward. Likewise, when the matron or nursing officer came on the ward, they were checking that all the beds were in line, with the wheels pointing exactly the same direction. And all the beds, they had to be turned down from there to there, exactly. They even measured to make sure it was. No one ever told me why we had to do that. I don't suppose anyone ever thought to ask. It was the same with aversion therapy. I didn't ask why, I just did it. It was the doctors who needed to know the whys, what ifs and maybes in my day. So it really does paint a picture of how, you know, nurses weren't taught they were taught to do as they were told. A good nurse was someone who kept their head down and, you know, got on with the task at hand and didn't ask questions. So like I said, very different to how we educate nurses these days. So I want to also pick up on some of the other treatments that were going on alongside aversion therapy to help contextualize and set a picture of psychiatry at the time. So there's some treatments here that were given during the 1930s to up until the 1950s, 1960s. And one of them that I'll describe is also still given today. So if we start, we'll go clockwise, we'll start on the top left, and this is a treatment called cardiazol treatment. And it was a treatment that was a precursor to electroconvulsive therapy. And what this would happen was the patient would be given an injection of cardiazol, which would make them have a very a seizure, a very violent seizure. And this was came about because there was a a mistaken belief that people with epilepsy don't suffer from schizophrenia. So they thought if we make people fit, have a seizure, then this will cure their schizophrenia. So this is why they identified that clodiazole would make people have a seizure. And we can see here, this patient is having a very violent seizure, and the nurse here is having to put something in a guard in his mouth to stop him biting his tongue. There was reports of this, there were patients' reflections on this and nurses' reflections on this. His patients understandably were absolutely petrified of it. And because they were completely aware of what was going on but had no control over their body during that time. And also it was the seizures were so violent that in some circumstances it led to fractured vertebrae and fractured limbs. So moving on from that was electrical convulsive therapy, and this treatment is still given today, but it's in a modified form. So it's in a much kind of tighter restrictions and much more humane than the treatment that I'm going to be describing now, which was unmodified ECT. So this essentially was given without a muscle relaxant or without anaesthetic, and they are both given now. So the patient is given is anaesthetized, so that they're not aware of the ECT going on. And this could be unilateral or bilateral, which means that the electrodes would be attached to either one side of the head or two. And we can see this is a bilateral ECT because the two electrodes here. Again, they would have to put something in the patient's mouth to stop them biting their tongue, because again, this was making the patient have a seizure. And the nurses, as we can see here, would have to hold the patient down often during the seizure, but also hold them down because they didn't want the treatment as well. So it was often given against their will. If we look now we'll go to the bottom left, and this is a patient being given deep insulin treatment. And what would happen here is the patient would be put into an insulin, a diabetic coma, and then they would maybe kept in that coma for 2 or 3 days, for an extended period of time. And then they would be brought around by passing, and this is what's happening in the picture, passing a nasal gastric tube into the patient's stomach. So that's a tube that goes up the patient's nose and into their stomach, and then pouring in a glucose solution to bring the patient's blood sugar back up. So again, a very invasive treatment, but probably the most invasive of all the treatments is this bottom right one, which is the lobotomy or leucotomy, as they're known in both the USA and the UK. And essentially what would happen here is the patient would be, they're awake during this time, so they're not anaesthetized, and they essentially a tiny ice pick would be put through the top of the patient's eye, and then a little hammer, as we can see here, would be tapped on that ice pick, and it was essentially trying to disturb the frontal temporal lobe of the brain. So that's the bit of the front of your brain, and that's essentially the part of your brain. It's essentially the part of your brain that's the filter. So it's the part of the brain that makes you think, oh no, perhaps better not do that. So they felt that because of disturbed behaviour, that part of the brain was faulty. So let's mess around with it a bit more and see if we can figure it out. And it really was as crude as that. And Walter Freeman was a huge advocate of that, and we can see him in the picture here. And you can just see the amount of nurses and doctors standing around, almost in admiration of this doctor giving this treatment, because it was seen as so revolutionary at the time. However, many patients, having received this, were left, very, very ill. Often they were unable to dress, feed themselves, and needed full nursing care following the treatment. So it didn't work at all and actually had a really, really detrimental effect. So the reason that I'm talking about these is that this was the culture of psychiatry at the time, during the particularly 1950s to the 1930s to the 1950s. There was the Mental Treatment Act that was published in 1930, and this was the first time that the word treatment, had been used in any legislation around mental disorder. And so psychiatry felt that, oh, well, we must start treating people, and there was a real proliferation of these somatic treatments. So the reason I'm telling you this is that many of the nurses that I interviewed also administered these treatments. So there was a culture at the time of nurses administering very invasive treatments to patients, and aversion therapy was an extension of that. So this is a testimony of Una Drinkwater, and Una was a nurse, and she was a nurse that had just, when she nursed the patient with who was receiving treatment for chemical aversion therapy for homosexuality, she was in her last year of retirement. So she was actually, when I interviewed Una, she was in her late 90s when I interviewed her. So she'd been nursing since the 1930s. And this is her reflection on this patient, and you'll see why she falls into this subversive nurses category. So this is Una's testimony. It's a quote: "I was working nights in my last year before retirement when I nursed," and she says his name, which I won't repeat, and I can still remember his name. I'll never forget it. Now, I'd always prided myself for showing the utmost of respect and courtesy and empathy for my patients in my care, and it sickened me knowing what we had to do to him and the futile hope of making him heterosexual. I just thought, where is the treatment in that? I couldn't see any benefit to it. It was punishment and torture, especially because this particular patient was on a court order, and so he hadn't really consented to the treatment. They were given a choice of prison or hospital. Many chose hospital, as who wants to go to prison? So I was desperate not to get involved with it, but I knew it would be more hassle than it was worth if I refused. Not only would my life have been made hard work because I would have been seen as a troublemaker, I also thought it would end up being someone else doing the dirty work, and they probably wouldn't have been as compassionate as me. So what I did every 2 hours when I was supposed to give him the injections was this. I went into his room and sat down on the bed next to him, and I asked him how he was feeling. He said he was feeling awful, and he burst into tears and said, "I just want to get out." I gave him a big hug and told him that I was going to help him. I told him that I was not going to give him the injections, but that I would come into his room every 2 hours as prescribed the injection and pretend to give it to him. Every 2 hours, I drew up the apomorphine, went to his room and squirted it on the floor, and told him to pretend to be sick in a couple of minutes once I had left. I reported to the charge nurse that I had given him the medication. I nursed him for 2 nights, and I spent time with him when the other nurses were on their break. I told him that if he wanted to get out, he needed to start saying he was feeling attracted to women, and that he felt the treatment was working. I got a thank you card and a letter for him a few months after he'd been discharged. He thanked me for the support I had given him, and he said he was living happily with tea. I remember he had confided in me that he was in love with a chap called Terence, so I presumed it must have been him. It ended by saying he would never forget me. I don't think I needed any special thanks. I just questioned things that a lot of nurses didn't. I'm a living, thinking human being. So that's Una's testimony, and you can see why she fell into that subversive camp. But I think it also highlights how patients could also subvert the treatment process as well, because there was no way of knowing the efficacy of this treatment beside the self-reported nature of it. So it was the only way the doctors knew that it was could determine whether it was working was the patient was saying, well, yeah, I do now feel attracted to these women. So I think it shows here that this particular patient that Una was nursing was also able to subvert the treatment process, because he kind of, you know, took her advice and said, yeah, I think it's working, and was able to expedite his discharge. So the aftermath of the treatments. So the treatments appeared to peter out, as I said at the beginning, with the decriminalisation of homosexuality in England and Wales in 1967, and the removal from the Diagnostic Statistical Manual, which was published by the American Psychiatric Association in 1974. But moreover, as I said at the beginning, the influence of the gay liberation movement. None of the people that I interviewed reported any efficacy, so they're all, you know, they all remain gay men or underwent gender reassignment surgery and living as trans women. But what they do all say is that all participants reported that they're still disturbed by the treatments they received. And this quote by Barrington kind of really sums up that. So this is Barrington's reflections on the treatment. To quote, "I've never got over it. I never have. I've never come to terms with it. A guilt, a guilt, a guilt, guilt. You can live with it, but how can I forget it? I desperately wanted the treatments to work, but they didn't. I can still have terrible flashbacks of my time in hospital and the barbaric treatments I received." So Percival underwent electrical aversion therapy, and he underwent that he went in between 1 and 2 times a week to have electrical aversion therapy for over a year. And he was so desperate it just wasn't working for him, and that's why he went you know, for so long in the vain hope that it would work, but it just didn't for him, and eventually he kind of, you know, realized it's not working, and kind of had to come to terms with his sexuality. So in conclusion, the testimonies show that the court's an unsympathetic family, police, media and social attitudes essentially prompted people to seek these treatments. And what the study does is it exposes the equivocal way in which patients and nurses read and listened to influential cultural outputs and acted in accordance with these. So remembering back at those news media articles and how influential they were in prompting patients to receive these treatments. There was a limited evidence base and no general protocol or guidelines, and there was huge variations across the country in the treatments that were given. As I said, the efficacy was based on self-reported outcomes of the patients, which led the patients and nurses to being able to subvert the treatment process. And the book offers some intriguing insights into the hidden gay lives of some of the nurses themselves and the inevitable tension between their own identities and desires and the treatments they administered to others. For the patients in this study, the treatments were ineffective and had lasting negative effects. And I think we can safely say that defining homosexuality as a mental illness and implementing ineffective and brutal treatments to eradicate it appears to have had a lasting negative impact on the patients who receive them. And I think this is really pertinent at the moment, given the discussion around banning conversion therapy. So it's envisaged that this study might act as a reminder of the need for health and social care practitioners to ensure that their interventions have a sound evidence base and that they constantly reflect on their morals and values and the influence that science, societal norms and contexts can have on changing views of what is regarded as acceptable practice. We can learn much from studying aspects of our own profession's past in which our actions, even if countenanced by the context in which they were suited, did not serve patients and society well. Thank you very much.
Tommy, thank you so much. As you take your well-earned sip of gin and tonic there. Thank you for that insightful presentation. It's absolutely fascinating. It's been a really interesting presentation and a really interesting discussion. Thank you again, Tommy, and thank you for being part of Morley College today on International Nurses Day, and also as part of Mental Health Week. We really appreciate your time. Thank you so much.
Thank you so much for the invitation. Thanks. Bye.